All right. Today is Wednesday, December 10th. It is 13:36 hours, and this is the Emergency Medical Services Advisory Committee for the State of Nevada Department of Human Services, Division of Public and Behavioral Health. My name is Ryan Mcintosh. I am the chair of this committee, and we'll go ahead and perform call to order at 13:36 and a roll call. Andrea, can you do the roll call? Rachel, sorry. Rachel, can you do the roll call? Sorry, I was and Andrea's name right there. So Rachel, will you do the roll call, please?
All right, I'm going to start with you, Ryan Mcintosh, Chair.
Present.
Thank you. Dustin Holland.
Present.
Thank you. Sandra Workout.
Present.
Thank you. James Johnston.
Present.
Thank you. Kevin Grannis.
Present.
Great, thank you. Caden Randall. Nancy Abrams. Mark Pincus.
Present.
Thank you. Chris McCann. Trent Schrotlin. And then for ex officio members, I have Bobby Sullivan.
Present.
Thank you. Dr. Deborah Cools. John Hammond. Andrea S.
Present.
Thank you. And Michael Bolo.
Present.
Thank you. We've met quorum.
All right.
Will you admit?
Yes.
Cool.
Oh, where'd they go?
Looks like somebody.
All right. Quorum has been met, and we'll proceed to agenda item number 2, public comment. Do we have any public comment in the room? And online, if you have any public comment online, will you please raise your hand and acknowledge you? Seeing no public comment, we'll move on to agenda item number 3 for possible action. Review and possibly approval of the minutes from the EMS Advisory Committee meeting held on October 8th, 2025. Has everyone received a copy of the minutes? And if so, take a moment to review them, and I will entertain a motion for approval. Got a motion by Dr. Holland in the room. Do I hear a second?
Second.
And a second by Sandy Warko. The second, we'll move for a vote. All in favor signify by saying aye.
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 Any nays or abstentions?
This is Kevin Grannis for the record. I'm gonna abstain since I wasn't at the meeting.
Gotcha. And that, you know what, Kevin, that's probably a good move on my part too. I will change my vote to an abstention also because I was absent. We hear no other nays. That's the affirmative vote. Minutes have been approved, and we'll move on to agenda item number 4 for information only. Discuss and provide updates on activities within the state of Nevada regarding emergency medical services. Agenda item 4A, update on the activities of the state EMS program. And I believe that's you, right?
That would be me.
All right, we'll hear from Bobby.
Thank you, Mr. Chair. Bobby Sullivan for the record. Nothing too overly dramatic, just some items to update this group on. Last month, we inspected Carson Valley Health down in Minden Gardnerville, and they became the first level 4 trauma center in the state. We're happy to report that. We completed inspections at the first non-emergent secure behavioral health agency. They are located in Las Vegas, so that one has come to fruition. That legislation's been around for 5 years. We've had over 10 agencies start the process and never complete it for multiple reasons. So we're excited to get that moving forward. Earlier this morning, we pushed out a complete list of permitted ground ambulance and air ambulance services in the state. We also pushed that out late last week to Nevada Hospital Association for help in distributing that to all of the hospitals, freestanding EDs, price spec, case managers, anybody that would need that information. We do occasionally identify agencies that are coming into the state to repatriate patients out of state that are not meeting requirements. So that way they'll have the updated list, you'll have the updated list. Moving forward in that document that went out this morning, we will keep the updated list on our website. So periodically, in fact, we're going out to inspect another new agency tomorrow. And after that successful inspection, we'll add them to the list. If anybody has any questions on that, just reach out to us. We're also going to provide that to Medicaid and Medicare and Office of Analytics for any of that billing through that path. We are seeing a little bit of a drop off in agencies successfully reporting their PCRs and image trend. So if you could reach out to your data person, or if that's you, check your settings, make sure your PCRs are coming through. If it doesn't look like it, please reach out to Kevin. We are starting a conversation with our IT security team. What we are trying to accomplish is setting up image trend or changing the settings on image trend so that providers can go in and reset their own accounts and not have to send us an email. You can reset your own bank account. We're trying to see, but part of that discussion is probably going to center around cyber attacks. How far do we compartmentalize and things like that? So that is one of the things that Mike's working on with our security team. Next month on the 22nd, our office is going to have an audit from Department of Public Safety on our processing and handling of backgrounds. Late last week, the offices in Elko were vacated. So currently staff are remote until other accommodations are located. So if you need to reach the staff in Elko, if you don't already have their email or their phones, send an email to the Healthy EMS account and you'll be put in touch with the Elko staff. Kind of some good news, and I have Kenny Pete on the phone here from Oahe as well. Idaho EMS identified some disconnect and some problems that Oahe was experiencing with their dispatch centers. Some of their calls are dispatched out of Utah. It became a real struggle. Idaho has offered through their state comm systems to take on dispatching for Oahe, which will help increase the efficiency and reduce dispatch times. So and they're going to do that before the end of this year. And they have also provided some equipment and some funding to pull that off. And we'll be going up there to support not only Idaho EMS, but Oahe to get that activated and get that going. So we're looking forward to that. That's all I have, Mr. Chairman. I'll be happy to take any questions.
All right, thank you, Bobby. And we'll entertain any questions for Bobby in the room and online.
This is the EMS committee meeting, all that I'm listening to.
Linda,
She's muted again.
you came across, was that a question?
That's negative. I'm sorry. I thought I had my mic closed.
Okay, no big deal.
Sorry.
Anyone else have any questions for Bobby on agenda item 4A, updates of EMS?
Oh, I do have, Mr. Chairman, my apologies. I do have an additional item. Can we step back? John, are you online?
I am. Sorry, I gotta
Do
find
you
the
have
mute
a
button.
moment? I'd like to defer and have John Middleman give a brief update. He attended the American Heart Association update last week in Arizona, and he's got a summary of that meeting. John, go ahead.
All right. Thank you. Like Bobby said, my name is John Middleman. And through the program they sent me out to Arizona for the AHA guidelines update, there's a few updates that pertain to EMS specifically that I kind of just wanted to touch on, make sure everybody was kind of looking forward to. Um, Kind of the same thing with 2025's update, early recognition and activation of 911, high quality CPR, early defibrillation. Um, all of that stuff has not really changed. They did change the chain of survival. So if you get a chance to pull up the highlights or look into the chain of survival, they added a couple of links into it. They also got rid of two separate links where we used to have a out of hospital link of chain of survival and then an in hospital. It's all one now. Um, as far as for us, key operational point is to perform the resuscitation where we find the patient, as long as the scene is safe and high quality CPR is feasible. That's one of the biggest things that they are pushing is on scene doing your treatment versus trying to load and go. They have seen better long-term outcomes from patients that were managed on scene rather than through rapid transport. As far as another big one that kind of pops was they are endorsing IV first and IO second. This is specifically driven by a lot of research that came out where epinephrine during cardiac arrest, if it's given through an IV, is more effective than through an IO and has better outcomes for ROSC and survival in the out of hospital cardiac arrest. So IO is still essential as a rapid backup when the IV is difficult or slow, but they want you leaning more towards IV first. So for timing, non-shockable rhythms, earlier epinephrine remains critical now. So if you look at the new algorithms, they have like a little syringe and it says early epinephrine. And they want you to give that, same 1 milligram every 3 to 5 minutes. But on a non-shockable rhythm, get it in as quickly as possible. They don't want anybody leaning towards any other vasopressor, such as like vasopressin or any of the vasopressor cocktails that are kind of going around. There's a few crazy things out there that they talked about, such as vasopressin and solumedrol mixture. It was kind of an odd one, but they don't want anybody going that way. As far as defibrillation goes, when it comes to unstable AFib and atrial flutter, cardioversion is now, they're pushing that energy all the way up to 200 joules for a biphasic monitor. Basically, they kept saying go big or go home was kind of the way the doctor that was putting on the conference stated it. And it has to do with instead of slowly escalating from low energies to high energies, that adds an electrical burden without better outcomes. So basically what they've found is if you just go up to the 200 joules in atrial fibrillation and atrial flutter for synchronized cardioversion, they've seen better long-term outcomes with that. If your department is looking into the double sequential defibrillation, right now they're not endorsing it. They're saying right now the studies have not shown any benefit from double sequential. They are pushing to make sure that your personnel are putting on the pads correctly and making sure that they actually have the heart between them, or endorsing anterior and posterior versus the standard way we do put them on. Naloxone got put into the BLS algorithm as far as cardiac arrest goes. It just got added onto the algorithm. We all know it's been there. They've been pushing it. They just added it into the algorithm as well. They did add a neonatal change as far as deferring the clamping of a cord to greater than 60 seconds or waiting till after 60 seconds to clamp the cord in stable infants or newborns. And that has to do with a study and the better outcomes for the baby if you wait a little bit longer to get the cord clamped. Another big one was the endorsement for end-tidal CO2 was basically don't use it as a sole indicator for ceasing or stopping a cardiac arrest, especially in pediatrics. You need to have multiple factors, not just end tidal CO2 of, say, 12 or 15 or below. To stop a cardiac arrest, you need to have other things, say multiple shocks or multiple no shock advises, or no shocks and asystole for a longer time type of a thing. They did change some things with the infant chest compressions. They no longer suggest the use of the two-finger technique straight down on the sternum. They recommend the two thumb encircling hands or the heel of one hand. So that was kind of a big change. Another one falls into the choking. They now, for children and adults, they actually endorse 5 back blows followed by 5 abdominal thrusts. The infants remains the same with the 5 back blows and 5 chest thrusts. The only difference is, rather than 2 or 3 fingers, they're recommending the heel of one hand for the chest thrust on the infants. And one of the biggest things that we got to focus on as far as for Nevada is making sure that we update our pediatric CPR and choking content, looking into our educational institutions, making sure they're adding this new information in, and making those changes, even at the lower level for our Heart Saver. If they're running an AHA program, it shouldn't be an issue. As far as the mechanical CPR devices, if you have heard that rumor that they are no longer endorsing or recommending the use of a mechanical CPR, such as the Lucas or the Zoll Autopulse, it's not that they're not endorsing it. What they're basically saying is it does not provide any better outcome than standard CPR. And so when given the option, they would prefer you to do manual CPR over mechanical CPR. Now, in rurals, we know that we don't have the hands. That is the exact reason why that's worded the way that it is, of unless something like shorthand, you're short on hands, that's when we really need it. So they're not saying don't use it. They're just saying limit it if you're in a setting where you have 6 personnel showing up on scene and somebody standing around that could have been doing the CPR. They do recommend, though, if you are going to use mechanical CPR, make sure you train heavily on it, and you get down the timing of being able to place the machine on, and limit your stops in CPR to under 10 seconds, like we always know. Termination of resuscitation or TOR rules remain evidence-based, but their use depends on basically what we have in our state law. You will see, if you get in there, there is now 2 different termination of resuscitation rules that they've posted: a BLS or universal TOR rules, such as a tiered system. You've got a BLS ambulance that goes out and an ALS chase vehicle, for instance, or an ALS only rule. And they kind of want you to stick to those if you're going to try to use something like that as far as a termination of resuscitation. Make sure your protocols follow something similar to that. Let's see. The post-arrest, one of the biggest things they're pushing now is, rather than a systolic blood pressure to look at, they're wanting us to start looking more heavily at the mean arterial pressures of equal or greater to 65 after ROSC, and avoiding hypotension, obviously. Temperature control, that one's another big one. They're kind of pushing back and saying, no, we need to be doing it. And even they said it while we were there, when I talked to them, was in EMS, it's not really feasible for us to be doing temperature management after a ROSC, but it is something that we need to consider when transporting a patient. Do the facilities that we're transporting to have that capability in an unresponsive ROSC patient to provide the better outcomes of long-term? And the studies come from not just, arrival to the hospital and release from the hospital, but 1 year later, after they've been released from a hospital, they've seen better outcomes for patients that have had that temperature management performed appropriately. One of the things they're pushing again is the crew safety and viral filters on your bag valve masks. So that is something that we've got to talk about as a state. Is this something we need to add into a standard for a bag valve mask, is to have a viral filter on the exhalation valve to protect our providers. And as far as the education goes, obviously nothing is a one size fits all. A lot of the programs that are getting built are starting to separate out, especially the Red Cross ones, and more at your lower levels than BLS, ACLS, and PALS. But your Heart Saver type programs, they're getting more of a individualized, piece by piece what you need based on your your needs rather than here's a big class, we want everybody to take it. So like Red Cross explained it, basically you can take Heart Saver for adults, or you can take Heart Saver for adults and AED, or Heart Saver with child, infant, AED, and adults. It allows you to piecemeal it. It's kind of interesting the way they're getting it set up. Now, as far as implementation timelines, AHA basically states that any card issued after, I'm pretty sure it's March 1st. They said after February, so I assumed from March 1st on. Must reflect the 2025 guidelines. If it's issued from March 1st on of 2026, and it has the 2020 dates on it, it is no longer valid. It has to have the 2025 curriculum, and all instructors will be teaching that. Red Cross plans to update their courses as of about February 2026, from what they told me. If you run HSI or the Health Safety Institute, they couldn't provide me with an implementation date yet, but they plan about the same way Red Cross does. Somewhere about February or March is what they're shooting for. And then, like I say, the only recommendations that I have coming from this visit was making sure that, department heads go talk to their medical directors, review any protocols that they may have, see if they will back the IV over IO on a cardiac arrest when feasible. And then the initial cardioversion energies for unstable atrial fibrillation and atrial flutter, up to 200 joules. And then just making sure that we update any other guidelines that follow. That is it from me. If you guys got any questions, I am happy to answer them.
Thanks, John. Any questions for John?
Hey, it's Zeb from TM.
Go ahead, Zeb.
Hey, so the Life Pack 35? They do that 360 biphasic. Did they discuss any of that?
They didn't address any of it. I know Physio Control was there and they were pushing it and showing it. But as far as what AHA was concerned, it was they're too new of a machine for them to do any endorsements or recommendations on.
Any additional questions for John? And we'll move to last call for any questions for Bobby on her updates. And hearing none, we'll move to agenda item 4B, update on the activities of the EMS program for children. Move to Mike.
Thank you, Chair. Michael Bolu for the record, and I'd like to provide the committee an update on 3 areas that we are currently working on. First is the Aegis distribution for the neonatal and infield delivery wraps. Distribution event started in Las Vegas on November 5th. Since then, our office has distributed 365 devices to 21 EMS and fire agencies throughout the state, and an additional 8 devices were distributed to EMS training centers throughout the state. Second topic is hand heavy. Our office, in coordination with PHP and HPP programs, put together a supplemental funding project to roll out hand heavy to 6 rural EMS fire agencies. That is slated to begin in Q1 of 2026. I provided a demo of the hand-heavy system to 3 EMS agencies this Monday. Waiting to hear back from 2 of them for final word of execution. If they do not want to participate, we'll be reaching out to other departments to get additional agencies on board. And then lastly is our emergency department pediatric readiness program. That program or initiative in general is called NV Pearl. It's Nevada Pediatric Emergency and Readiness Level. We've designated 4 levels. One is for trauma centers that are approved through ACS to be a pediatric trauma center, and then 3 additional trauma center designations, 1, 2, and 3. And then the other 3 are specifically for hospitals that do not have a trauma center. We got delayed on that project with the government shutdown. We did hear back from HRSA last week. They had some questions for Dr. Horning, who's the chair of the EMS Advisory Committee, and I. We responded to those questions. We're waiting on a final green light to start that initiative. We have 2 hospitals that volunteered to be part of our pilot program. Both were located in Las Vegas. That is all I have for the committee. I'm happy to answer any questions.
Thank you, Michael. Any questions? Seeing none, we'll move to agenda
Yeah,
item
I'm-
4C, update on
sorry,
the activities. Oh,
okay.
do we have a question online?
Yes, I'm sorry. I should have raised my hand. I was struggling here.
Sure.
I'm just curious.
Let's
This
go
is
ahead.
Dr. Cools. And I'm just curious which hospitals agreed in Southern Nevada.
It is UMC and Sunrise.
Okay. And I didn't quite catch exactly what the pilot was to do.
This will be the first time an ED pediatric readiness program has been implemented in Nevada. Several states have already implemented it. So HRSA recommends doing a pilot program. We're not opening up applications. We could probably take 1 or 2 more, but not opening up applications to all hospitals till we get all of our internal processes streamlined so we can handle that volume. So right now we're just looking for, once we get the green light from the feds, have a handful of hospitals that we can work through the process, figure out our application process, site visit policies. And then when we kind of get the ball rolling, then we'll open up the application to everybody.
Okay. And this is for transport for all children or just injured children?
So this is specifically for pediatric readiness in the emergency departments. It is not
I
an
see.
EMS.
Okay.
Yeah,
Okay,
so
got
it's
it.
basically the staffing, the training, the equipment EDs readily have available to manage their pediatric patients.
Great. Okay. Thank you so much.
You're welcome.
Any additional questions for Michael?
I have one. If, sorry, Dustin Holland for the record. If emergency departments are interested, are you going based on the standardized pediatric readiness stuff that's already been published, or are there things specific you guys will be looking at in the application?
It is pretty standardized. It's from the EDC and the EIIC, their pediatric readiness program that's being pushed to the EMSC program. So if you guys are interested, by all means, I'd like to get 1 or 2 Northern Nevada hospitals on board.
Has Renown shown any interest?
Well, the doctors on my committee, yeah. So
Those, are you saying you're interested?
Well, I'd have to run through our command in the hospital, but it's something they've been looking at. Then it kind of fell right wayside with COVID. So I was just interested if there's a checklist to kind of see if we're in that ballpark.
there is,
so that that's why-
we kind of got ahead of ourselves. I can't publish the checklist and equipment list and training stuff until HRSA gives me the go ahead, but I do have that. So if you're interested, I'll make a note and I can send all that information over to you. But we have 4 levels, anywhere from a pediatric level 1 trauma center, which I don't believe we have in the state yet, which is sad, all the way down to a freestanding ED or full access hospital. So the 4 levels encompass ideally every facility that we do have. So just because you're not the pediatric advanced plus or trauma plus program, you could still go for any of the other 3. Yep.
Question, have you heard anything from the critical access hospitals about participating?
Have not.
Do you have trouble connecting with them?
I do. I asked my physicians on the EMSC committee because
Okay.
they have an internal network of people who they know. But if you have a contact list, I'm actually working on a.
If you could give me more information, I think NRHP, the Nevada Rural Health Partners, they would be good for that.
Yeah.
Okay,
Dr. Coles online, did you have another question?
No, let me lower my hand.
All right. Chris, online, you see your hand?
Yes, can you hear me?
We can.
Oh, wonderful. I just put a note in the comments about if somebody is interested in Renown participating in the Children's Readiness Program. If someone could call me, I could at least get you to the right folks to coordinate.
Thank you, Chris. I will find your information somehow. I'm sure a quick Google. Okay, perfect. I'll have Bobby give me contact information. I'll send that over to you. I'm not sure who Dr. Jensen and Dr. Horning may have contacted for that facility. So I will reach out to you as soon as I get out of this meeting to get that going. I appreciate you helping me out.
Yeah, that would be great. I'm happy to help. Thanks.
Any other questions? Seeing none, we'll move to agenda item 4C, updates on the activities of the Southern Nevada Health District. Mr. Hammond, I don't believe is with us today. Is there anyone else from Southern Nevada Health District that would like to provide an update? No update for agenda item 4C. We'll move to agenda item 4D, updates on the activities of the Northern Nevada Public Health. Ms. Andrea Esp, I believe you're online.
I am Andrea Esp, Preparedness and EMS Program Manager for the record. Just a few things to update you guys on. After the passage of AB 102 last session, we have now developed a work group to assess the feasibility of taking on such authority here in Washoe County. The work group will meet for the first time on January 15th. And I do not have a timeline for you for when that work group will determine their recommendation to the District Board of Health, whether to move forward or not. But I will continue to update this group as we move forward. The franchise for ambulance service in Washoe County has been revised and is slated to go to the January DBOH or District Board of Health for approval. And then just starting on the annual franchise compliance report, of which I will provide an update to this group in our next meeting. That report is anticipated to be completed before this group meets again. And those are all the updates I have for you at this time.
Thank you, Andrea. Any questions for Andrea? Seeing none, we'll move to agenda item 5 for possible action, discussion and possible action to recommend Ryan Mcintosh for a second term as member of the EMS advisory committee for an employee of a volunteer firefighting agency at which some of the firemen are employed and some serve as volunteers. And we'll open that for discussion. And I have one for you, Bobby. Was this put out for applications? It was not put out for applications. Are we required to put out for applications when there's a term expiring?
If we're gonna have a term expiring, we start putting those out if we know there's gonna be, especially if you have a 2-year term, because we do 2 2-year terms. But traditionally we have not, because it's been the pattern of this committee to keep those members on for stability, to keep that instead of starting fresh every 2 years with the associated positions. Happy to table it if the committee would like to. We could go out and post, and then I would recommend meeting early in February for a decision, because in order to get those approved, the next Board of Health meeting is the first Friday of March, which I think is the 6th. That would be the soonest that we could get BOH approved.
Thank you. And for the record, so we don't have any clear or any ethics complaints or anything else, I'll refrain or abstain from this, because clearly I have a conflict, so I will not participate in any further discussion or a vote. So any other discussion?
Would you like me to take this for a second?
I would.
Does anybody have any discussion or comments? Would anybody like to make a recommendation?
I would like to ask, do you want to stay on?
I have no problem and love to continue to serve this board. It's been an experience. I don't think we meet frequently enough to really make it productive, but given that I'm not a frontline provider anymore,
Put
that
that
helps me
down
stay
in the
engaged
motion.
in EMS. So, yeah, I would love to continue to serve on this board. If that's the wishes of the rest of the board.
And to be clear, quarterly is, or 4 times a year is the requirement under regulation. We can meet more frequently. Anyone online have any comments or recommendations or motions?
Mark Pincus for the record. I'd just like to move to nominate Ryan for another term.
Motion's been made. Is there a second?
This is Kevin Grannis. I'll second.
Okay, motion's made and second. All in favor, say aye.
Aye.
Opposed? Any opposed? And 1 abstention. Anybody else abstaining? Motion's carried. Congratulations.
Thank you. Look forward to continue to contribute. We'll move on to agenda item 6 for possible action, discussion and possible action to recommend Kevin Grannis for a second term as a member of the Emergency Medical Services Advisory Committee as an employee or volunteer with a medical facility located in a rural area that provides emergency medical services. We'll open 6 for discussion.
First of all, I think we ought to ask if he's interested in maintaining.
This is
Kevin?
Kevin Grannis for the record. Would be very happy to continue my service.
Thank you, Kevin.
Any other discussion? To a motion? You would like to make a motion to nominate Kevin Grannis for a second term on the committee?
This is James. I'll nominate Kevin Grannis for a second term on the committee.
Thank you, James. I'll make a second. So we've got a first and a second. I'll call for the vote. All in favor, signify by saying aye. Aye.
Aye.
Any opposed? Any abstentions? Motion moves. All in favor. Congratulations, Kevin. We'll keep you for another 2 years.
Thank you. I'm happy to stay.
Agenda item 7 for possible action, discussion and possible action to establish annual goals for the Emergency Medical Service Advisory Committee. I believe that this is somewhat of a standing agenda item now, so we can start to set some goals and make these meetings productive, because I just said we don't hold them enough. But careful what we wish for, right? So I believe that this is an item at the request of Ms. Warco, so we'll open for discussion.
Yeah, so this group has had opportunity to look at some of the goals for the advisory committee, and we wanted to make sure that we kept those in line with the duties of the committee per NRS. So in looking at some of those goals, we've come up with about 5 that we feel would be productive for this committee. I don't have a good process of how we're going to put these goals, because it would require stuff going out ahead of time and then coming back and discussing it, such as our NRSs and NACs 450B, are they meeting the intent of what is happening in the EMS world in Nevada? So that would require us saying, okay, on this day or on this next meeting, we would like to review these. Please review and be prepared to discuss. Do they meet the intent? Do they not? And if there's a recommendation for a change, what would that recommendation would be? So I don't know what the best process for that would be, Bobby, if that would come from your office, if you could break those up and send them out ahead of time for us to review and bring for discussion. So that was goal number 1, is the review of NRS and NAC, and are they actually meeting the intent? And then if we have changes, what are those next steps to bring that to the legislature for change? Our second goal would be reviewing application and EMS forms, not the applications themselves, but the application process and the forms that are a part of EMS. And again, that would require, can we I think this would be more in line with what you guys are hearing complaints about, maybe from applicants, and that we could look at those forms, and is it is it something that needs to be changed, or do we as an advisory committee feel like these forms are sufficient and why they're sufficient? So that would be a goal.
I did want to add on the forms. So the traffic that we're getting back on this has dramatically dropped what we're in there doing now as we're going in and making grammatical changes. Yeah, I'm twitching, but we're in and we're making those grammatical changes. We're also in the process of extending the contract with Image Trend. So we've got that tie in there as well. But right now, documentation wise, we're not seeing any other than the normal, hey, I waited till the last minute and I want to do it all at 1 second. And I did all of my training in one night.
What department does that?
All of them.
No, I mean, like, the providers, not the agencies.
That's what I meant.
No.
All of them.
I know.
No, not the one ranger. So we just, to the group, we are working on cleaning that part of it. As it stands now, when the contract renews in June, we've been under this Image Trend system now for 7 years. 7 years?
It'll be 8 years.
8 years, 8 years at the end of the contract. So, somebody had said, what do you do next? And to store that amount of legacy data would be a huge undertaking. We're storing data from our prior version. So, but just so you know, we are updating the grammatical struggles.
All right, and so maybe this is, would be just something that as the department saw an issue arising, that maybe it could be brought to the advisory committee for discussion.
Sure.
I think that would suffice. One of the things that in that goal was that consideration, I think we've talked a little bit about this, of aligning with other medical or health professional boards, and that instead of everybody annually renew, I mean, they all have to annual renew, but auditing CEs and stuff like that, instead of sending it all in one application. So it seems like the system has, I'll use nursing board, right? I have to renew my license, but I don't have to send in all the materials unless I get audited. It's still required that I have that available, but I don't have to send in all of those documents about all my CEs and all of the other stuff unless I get audited or I'm chosen for fingerprinting that year.
Okay, and we have the fingerprints on the 6-year cycle. That one we can't get away from. And then as far as the education, we've got that tie-in that you can push your CAPC education or anything that you're training into Image Trend, which will drop in your folder and your education. So that may help.
It might be a moot point.
No, just
because Image Trend, I mean, it seems like
we keep trying to upscale every chance we get.
So I think originally that was kind of one of the goals. Do we want to look at a system that is similar to, I think, State Board of Medical Examiners does the same thing, right? You get audited and then you have to provide all of the extra documentation.
Okay.
And then assisting the state with the EMS policy and procedure manual, if that's something that, you have a portion that you've worked on and you want to send it out to the advisory committee for review and then discussion, we would be happy to be helping with that as far as reading, editing, and evaluating that. And as an agenda item, maybe as part of the goal is just that we identify and highlight any critical issues that are facing EMS. Probably not for action, but a discussion, and just have it there. Does anybody have any or identify any critical issues that we should discuss and be made aware of? And then the last goal, which is goal number 5, is there any opportunity for the advisory committee to be able to review the budget of the EMS program? I don't know if that's ever been brought to where we actually can see that budget. And some of that is when we're looking at that, is there ways that we would be recommending that you increase fees or the budget's not sufficing? That's just a thought.
No, it's been a thought. Just a side note to that on that topic. In a couple of weeks, we're going to start budget building for the I always get this backwards, 27 biennium. Yeah, FY 27, 28, 29. So we start those next month. I'll see where we stand on that, because those are built out 2 years in advance. So yeah.
So I think that I'm going to speak for myself, but as an advisory member, I have no idea what your budget looks like and is where are your struggles and, you know, where could we advise on that if you have a group of people that do a lot of budgets. And so there might be opportunities that if we had the ability to see the budget, that we could recommend something as well.
Absolutely.
So, and then just lastly, minimum care standards for EMS. I think we've started that. We've got the medication list today. And so that would be something that goes along with the goals of the advisory committee, is to help with the standards of care for EMS. Any questions on that?
Any questions or further discussion? I have a recommendation to staff to see if we can do this. If we can make a standing agenda item to try to achieve these and make it a workshop for discussion and possible action. And if it takes us 15-30 minutes to get through some of these items.
Yeah.
And then with that, I would request if we could get, obviously anything that we're going to provide in material is going to have to be in the backup when these get posted, so that when we, if we can get out, say something 15 days in advance of the next meeting, say request to the committee board members what we would like to use that workshop time for. And that way we can get staff to compile whatever backup documentation we would need to be able to review. And that way we can review it within that period of time. It's included in the agenda packet, and then we can have a quick workshop at these meetings and see if we can accomplish some of these goals.
I'd like to recommend that we take, Bobby Sullivan for the record, take it slow on the first agenda, because when we push those agendas out that far, if we run into problems and we have to repost them, then we're doing this with the date to make sure we meet open meeting laws. So I completely agree with you, and we'll just start building on it.
I will not micromanage that at all. If we can work on those concepts with staff, obviously we're an advisory committee, so
No,
if we, as staff could work on that request.
we appreciate the help.
We would love to see if we can catch some traction on this.
Yep.
Any other discussion? I think 7 was a discussion, no action will be taken. There was some requests for staff to see the feasibility of a standing agenda item for workshop to meet the advisory committee goals. And we'll move on to agenda item number 8. For possible action, discussion and possible action for the recommended medication list provided.
Mr. Chairman, Bobby Sullivan for the record. Before I turn this over to John Middleman, we did receive some feedback about some of these items on this list, and this list is generated as a base following standards, and we're trying to eliminate the necessary step of agencies trying to add to their medication list that in some cases would require a presentation to the Board of Health, and we're trying to streamline that as a minimum. There's 2 versions of the list. One is alphabetical and one's by skill set. I'm going to step out of the conversation now and let John go.
Hey, John, Ryan Mcintosh, real quick, can I interrupt you? Zeb, did you have a question with your hand up? Is it procedural in nature?
It is not. It's for after John's done.
Can you speak up a little bit more, Zeb? I couldn't hear you.
It's not procedural. It's, I just want to make the comments after John's done.
Okay, let's hear from John first. Let's have him give the presentation, and then we'll get to you with your question, if that's okay. All right, John, floor is yours.
All right. So Bobby kind of hit the nail on the head for me. So this is John Middleman for the record. With creation of this list, basically what we did was we took all of the medications that current Nevada providers were already utilizing. We added a few additional ones based on some national curriculum. Stephanie Mead actually probably added, I think, 8 to it when she gave me her feedback. We had a couple from the volunteer agencies in the eastern side of the state that were asking for specific medications. Like I'll give you an example. Initially, when I first sent this out for review, Phenegrin fell underneath a paramedic, and now if you guys look, Phenegrin falls underneath AEMT. I actually took flack from 3 separate departments on that one. because there is 3 departments that currently carry Phenegrin for their AEMTs in the state. So it was one of those things. I tried to take a lot of the input from everybody. I talked to several different medical directors, looked at several different state protocols throughout our state as well as surrounding states of what was allowed. And I tried to make a good medication list that would be accessible to all permitted agencies, well, anybody, so that if they were going to create their protocols, they had a good medication list of, yes, you can do this at an ILS level, or you need to be an ALS if you want to push these medications, or if you're only going to be on a BLS rig, this is what's allowed. That was the goal. This is to limit the number of times that providers need to go in front of the Board of Health for a variance. Now, there are some things, and I know we've had a lot of people that want to push, say, for at least some narcotics at the advanced level, say fentanyl. We have several departments that are already utilizing fentanyl at the ILS agency. They have variances, and they're actually having pretty decent success with those. We're not there yet because there's actually an NRS that doesn't allow us to actually utilize those meds for an ILS agency. But this is a good starting point. From here, we can take this list with any changes that you guys recommend, take it to the Board of Health if needed. I'm not sure if Bobby, we decided that was where it was headed next.
I don't have an answer back yet on that. So what John's speaking to is after the discussion about this list today, we're going to present it to our council to see if it's something that we can do based on how it was built and what standards it was built on, or do we need to take it for the Board of Health? And if it needs to go to Board of Health, I'll put it on the March agenda.
Okay. So if it needs to, then I will happily present it to the Board of Health with Bobby's help. And like I say, any recommendations that you guys have as far as changes you would like to see. I know one of the biggest controversies, and I'm waiting for Mark to chime in. It is the atropine for advanced instead of for paramedics. Almost everybody has said no, TXA is just fine. Those are the 2 main ones that actually currently could pose an issue at the advanced level. As far as, right now we do have departments out there that have a variance for TXA. We don't have one yet for atropine, but I have 2 that I know have reached out to me and asked me the processes. Well, one's warning me they're coming back after a variance, another variance. And then the other one is, hey, we want to do this, and how do we do it? And so we're trying to prevent that, hopefully, so that we're not having to go through variances all the time. With this, it gives, yes, a wider scope for our ILS agencies. But for instance, like atropine, that's a key thing. If you've got a patient that's in bradycardia and hypotensive, and you're an hour from a hospital, the atropine could mean the difference between that patient coding in the back of the ambulance or sustaining until they arrive. So that's all I have. Any questions you guys might have, I'm happy to answer.
John, first off, I'd like to say I really like the list. It's a comprehensive list, and it takes away that need for those variances, but puts a lot more in the capabilities of our medical director's hands for them to determine the appropriate medications that we should be carrying and at what level for our service needs, especially in rural Nevada. So I really like the motion that this is headed in. And that doesn't eliminate the other checks and balances that the regulatory authority of the EMS staff have. And, having gone through protocol review with this staff here in the past, I really believe in that process to make sure that if we didn't have if we had a medical director that wasn't really up on his game, was allowing some of those more practices that we don't really feel safe in the oversight of some of the EMS programs, that I know my organization alone has been called on the carpet a couple times by this staff, and I've learned a lot from that process. So putting some trust in the system, I think that this medication list is a good improvement. So we'll open it up to further discussion and questions. Zeb, did you still have a question? Mark has a question. Go ahead, Mark.
Mark Pincus for the record. John and I have spoke. I like the idea and I really like the list. I think it's pretty comprehensive and opens up a lot. My concern is, as John stated, is with the atropine. It's my feeling that anytime atropine is used, there should be a heart monitor and a 12 lead attached to that treatment. It's not the AEMT administering the atropine, it's having the atropine on board with an all advanced system. I'd like to hear from more medical personnel if there's any concerns in that matter.
So this is Sandy Worko for the record. So we did have discussion on this as well, Mark. In reviewing the assessment of a patient who is bradycardic, which you can do through an assessment of the patient without a heart monitor, bradycardic and other symptoms, I don't think it is going to hurt the patient, and it is possibly definitely going to benefit the patient up until they can get transferred care to higher level. It does not require you to reassess other than reassess, is the heart rate better? Is the blood pressure better? If it's an advanced EMT, they're able to give fluids along with that to increase blood pressure. So in working through outside of the box here, I think it is safe, and it's safe for the patient, and it has more benefit than it does harm to the patients, especially in rural Nevada.
Dr. Holland, can I ask your opinion?
Yeah, I think there's a few things. There's medications on here that have several indications, right? So atropine, we think about anticholinergic uses. I mean, that might be very helpful, especially with an MCI and you're transporting with advance. For symptomatic bradycardia, probably not relevant to my agencies. I think having a paramedic with a cardiac monitor and getting a 12 lead to understand why are they, but having it on here as an option so the individual medical directors can at least feel comfortable approving that for an agency who might need that. I think that's relevant. I see a few notes where critical care paramedic is noted here. There are many medications that aren't on here that are given by critical care, transport. Is that something that we feel we need to include? And has anyone from, our flight programs been included on this just to avoid that pushback? Or is that kind of a separate entity altogether?
So I did not address the flight programs as of yet. I figured that would be a next step. The reason why those ones got thrown on there was because I originally had them at the paramedic level, but I had enough feedback to say, no, these probably should fall onto a critical care paramedic. And I didn't see a need to pull them off. So I just left them. I think eventually at maybe a second round of building medications, yes, I think we need to take a look at what are our flight crews using? What are they allowed to use? It's no different than, and Bobby can attest to this, having a flight crew asking for finger thoracotomies in the field where that tends to fall, yeah, make him chuckle. And that tends to fall outside of a flight crew scope of practice. Now, so we do need to rein them in, yes, I think, but we see less problems with them. They're asking for very little variances, whereas we have a lot of our rural agencies that are asking for several.
Cindy, I see your hand.
Yeah, can you hear me okay?
We can.
Okay. I was just going to echo what Mark was saying earlier in the hesitation of the atropine and well, I mean, the atropine's the big one in the case of we thought it was actually going to be for a recommendation of adding atropine for a duodote situation, not for just bradycardia. But I think specifically in the case of, like Mark said, not having a cardiac monitor and being able to look at a 12 lead and make sure that your patient isn't having a STEMI, because I mean, in our protocols right now, the Washoe County regional protocols, it does specifically say that it is contraindicated to give atropine in a bradycardic patient that has ischemia or a myocardial infarction. So I don't know. From my end, I don't know if you spoke to cardiologists. I would almost think like reaching up to that higher level, and maybe you did already, and they were the risk outweighs, or the benefit outweighs the risk. But that's just my 2 cents on adding those in particular.
So I have I've a few medical directors, and all of them have kind of given me the same foresight of the benefits outweigh the risks. And I don't know how many people would be able to see my screen if I were to share it. But I'll share it really quick if I can. Maybe.
And John, while you're pulling that up, I did want to add to the group. I cannot off the top of my head think of one agency that does not have on their ambulances a cardiac monitor. So they have the opportunity to send that over to the EDs that they're transmitting it. Thank you, I forgot the word. Transmitting that reading over to the EDs for that support.
I think in my opinion, the big indication here is we're putting it out there, but the medical director still has to include it in the protocols. And that medical director is going to determine at what point that medication may be administered. You know, is it bradycardia with profound hypotension to the point where it is beneficial? And what training has that medical director provided that staff to make sure that it's being done appropriately? And does the medical director make it a level 2 medication in that protocol, so they at least have to make base station contact? And like Bobby is saying, if they can run a tracing and transmit it to a doctor that's at a hospital 30 miles away, and it is the one thing that may save a life, are we tying our hands of a medical director in a very rural setting that this may be beneficial to because he doesn't have paramedics in the field? And we're not saying it's going to get used at this level. We're adding it to the list where a medical director may be able to use it in the right opportunity. So go ahead, John. Sorry, unless
I was just gonna piggyback on that, Dustin Holland for the record. You know, a good example is we're in the early process of building a paramedic program in our hospital, and they are very much interested in looking at what is approved at the state level, and we don't want to go above that. So having the opportunity to introduce these medications at different levels when appropriate it is much easier for us to get things done than have our hands tied and be applying for variances. And so I think it is totally fine to leave it in there. And, you know, like STEMI was mentioned, yes, it's not an absolute contraindication, but it is highly recommended that we don't do that. But that comes down to good, rigorous protocols that are evidence-based, which is very hard to manage at the state level, you know, looking at all that. So I would recommend leaving it in and letting it be managed more at the local agency level.
Hey, this is Zeb.
Who?
Can you hear me?
That's Sam again?
Right. Yeah.
All right. Go ahead.
Yeah. So, I mean, not against it. I guess I need to understand what the variance process is. Because is there a training component tied to when people submit a variance or other departments submit a variance? And the second part of this is, it seems like the medications are just listed on here as they can give the medication regardless of what etiology we're looking at. So whether or not it's organophosphate, symptomatic bradycardia, or whatnot. Because if we're looking at symptomatic bradycardia, blood pressure problem, you're not giving atropine, you're probably going to give epi, right? Because that's going to do alpha and beta at the same time rather than atropine that just does chronotropic effect. Where if we're looking at atropine for organophosphates, you can deliver atropine and a lot of it for organophosphates, right? But if we don't add the 2-PAM to that at some point in time, They could also have diaphragmatic paralysis. They could have weakness in the intercostal. They'll have respiratory issues continuing, even though we're treating the symptoms. We're not necessarily getting rid of the acetylcholine from those receptors. So I just want to make sure that we're looking at this thoughtfully, and whatever liabilities might be tied to any of these medications that we're approving to the state.
Chief Johnson, I see your hand. Go ahead.
Yes, sir. Thank you. This is James for the record. You know what's this conversation is, it's mirroring an exact conversation we had, I want to say in 2004, when nitro got put into the AEMT curriculum, and then also into the state protocols when we were adding into ours. And the right-sided MI came up, and it was almost mirrored this exact conversation, right? Like, is the risk versus the reward, and then what due process do we put onto the agencies for training and understanding? And the same result ended up saying, hey, if you're not competent enough to understand what you have or what's in front of you, or even if you're going to give that's a nitro to a right-sided MI as an AEMT and not know or understand that, because that's a very big reality in someone that's not cardiac monitoring. So I think we already have that exact same level. We could go high level on nitro, and I can guarantee you that we would probably have an even worse outcome if nitro was given to a right-sided MI. So I think it comes with logic, right? It has to be with training, and it has to be with individual agencies making sure that their protocols are met and understood.
Mark, I see your hand. Go ahead.
Just two more comments. Number one, I'm happy we got the discussion going. I'm not totally against it, and I'm actually, after talking with John and the committee, the issue of the atropine, while I do have concerns, ultimately it is up to the medical director, and so I'm pretty satisfied with that. My next comment, though, is I noticed, and I'd spoken with John about this, on one of the lists he mentioned, I think it was with nitroglycerin, that it should be only allowed for EMTs as a patient assist medication. And I just wanted to bring up the issue of, in 2025, I think we have to recognize that anytime we mention patient assisted, we're really administering the medication. And it's time to stop hiding behind that little phrase there, patient assisted. So I don't know what the feeling of the committee is, but I would just like to see that terminology disappear. If you can give the medication, give the medication.
Yep.
And the one thing I hadn't thought about it with that, Mark, after we spoke, I kind of thought about it was, rather than patient assisted, is patient prescribed medication.
Absolutely.
Yep. All right.
So to the question, Bobby Sullivan for the record, to the question about the process for a variance, any variance has to go before the Board of Health, has to be submitted to administration a minimum of 45 business days before the next scheduled meeting. So that means if there's a holiday in there, you got to count in an extra day. That includes there is a template format, and then you supply the backup information for that. Explain why you feel you need that. Part of the process includes a review from this office that comes back either as neutral, in support, or against that variance and the rationale. Those have to be submitted a certain time frame before the meeting. As with this committee, the Board of Health only meets every 3 months. So if you miss the deadline for the March meeting, which is coming up quickly, you wouldn't go till the next meeting till May. So this was also designed to help alleviate some of that. But I also want to point back to, as the medical director and as the agency director, it is that agency's responsibility and the medical director's responsibility to ensure that the personnel have been trained correctly in all aspects of the operations in those protocols, whether it's using devices or using medications or anything else. We do, on variances that are supported require demonstration showing the training program. And in most cases, if the personnel are unable to meet those standards of the variance, they're simply not allowed to do it. We have one agency that had an AEMT level skill set that was specifically designed that they were checked periodically. They failed to meet competency, it went away. So I think it kind of ties together, not only on the front side from your regular protocols, you have to determine competence or remediation or however that looks, but we also add that key to any of those variances to keep the consistency.
A quick question of that, Bobby. Variances are not permanent, correct? They have to be revisited.
There are currently no expiration dates on variances unless they're instituted.
Gotcha.
The only thing that has a variance currently is driver program. And that's 3 years. 2 years, 3 years.
So, so with that, Bobby, like, that seems like it's a relatively good safeguard that's in place. Is there a, other than the ease, like I totally understand the ease of getting these things through process and going through boards, it's kind of a pain. Is there a way to make the variance process different and make it easier? But having that
Not at
safeguard
present,
of training there.
not at present, because that's a Board of Health requirement. That's not something from here. That's the process that everybody taking a variance to the Board of Health, whether it is behavioral health facilities for kids or adults, or, you know, building sizes or numbers of bathrooms, anything that goes from the Board of Health has the same process.
Okay. And I do have another question for John. You had Solu-Cortef and Solu-Medrol tied or on the list. What was the reasoning for both? Since they both kind of do the same thing, except for one is not a mineral, I don't even call it sparing, retaining medication that could be dangerous for patients that may have a history of CHF. Even if you have COPD, CHF, or asthma, CHF tied to it, like, is that one we want to keep on the list and just keep the Solu-Medrol as a potential use?
What was the second medication? Solu-Medrol and what else?
The Solu-Cortef.
Oh, so I added both because we have volunteer agencies that one carries Solu-Medrol and the other one carries Solu-Cortef, so they were both already carried at the AEMT level. I do know that the one that is currently carrying the Solu-Cortef, they were phasing it out and going to Solu-Medrol. So I would happily pull Solu-Cortef off if you guys felt, or move it to a paramedic if you guys felt that that was something needed to be done. But I don't know how that would affect the current agencies that are carrying it.
All right. Any other questions or discussion? Jamie Carlson, I see your hand. Go ahead.
Yeah, I don't know, like, just for the Solu-Cortef, and it does fall more paramedic. I would just tell you that one is the one for adrenal crisis. So if those agencies in that area have patients with adrenal emergencies, that is the better medication for them to carry, and they are trying to push that. They've been trying to push that, but I don't know that that doesn't fall towards more paramedic as far as medications. So just that thought process. And then I would tell you guys too, if you haven't looked at the research for AHA, their new research that they've released, that's a good reference for that atropine as well, for the advanced EMTs to be able to carry it.
Thank you. Jamie, Bobby's got a comment to that.
Also, I just wanted to dovetail on what Jamie said and John said. The Solu-Cortef was for a rural agency with actually a member of the agency with the adrenal insufficiency. So that was specifically designed for that community and that patient. So I'd leave it to the group to decide if you want to leave it there. That child, I believe, has since relocated, and that's why they're phasing it out. So just for clarity. And John, you have two representatives in this room right now from Air Services that would probably, at least one of them, help join in on that discussion moving forward on air medications.
I will happily take any input.
Thanks, Bobby. Any other discussion on the recommended medication list. I think the big decision here is whether we're removing restrictions and enabling our medical directors to be able to have more leeway in determining the appropriate medications for agencies to be able to utilize according to their protocols, their diverse natures that we see across the state of Nevada, because we're not all small organization or large organizations with the multitude of resources that are close to hospitals, and that we all have to have some sort of dynamic ability to be adjusted. Our scoping with it puts a lot of trust in our medical directors to be able to determine that. And they went to med school for a really long time. We trust them to write our protocols, and it's not just a check in the box. And I think Nevada's come a long ways with its EMS abilities in the last 20 years. And I think we've really professionalized the medical direction of our organizations. And we're not just using community doctors anymore. We're actually like central. Quite a few organizations in the region have been invested in a medical director who specializes in EMS. And I think that's where we're really headed. So I'll reiterate, I support this as drafted, and if there's no other discussion, I'll open for a motion.
What, can I ask, what is the motion for? Because like we talked about, adding more medications for critical care paramedics and stuff might be necessary. So I'm just curious, what are you motioning for?
I'm not making a motion. I'm opening it for somebody else to make a motion. But I support it as drafted to recommend to staff to take it to the Board of Health for adoption so that we modernize where we're at now. That would be my recommendation, but I'd open it for a motion from any of the community or committee members as to what they'd like to see for action on this.
I mean, I would not recommend to adopt it as is until we either have a caveat that critical care paramedic transport is excluded, and that might even be too big of a, something to tackle, because those medications can get so in depth. So if we just have a, disclaimer that is excluded from this, and this is for just ALS and below, then I would support that.
Would you like to make that motion with those amendments to this, with direction of staff to make those amendments so we can get in line with the Department of Public and Behavioral Health for the next meeting, with give staff some time to get all this prepared?
Yeah, I'll motion.
All right, so we have a motion to recommend the recommended medication list to be amended to remove the critical care paramedic references, correct? Is that what you're after?
Correct.
And do we have
James, I'll second.
We have a second from James Johnson, and we'll call for the vote. All in favor signify by saying aye.
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 Any opposed? Any abstentions? All in favor? The motion passes. All in favor? Or unanimously. Why am I saying all in favor? I did twice. So unanimously passed. Thank you guys for that discussion. I think that's one of probably the better discussions we've had in this group for a while. And I believe it was very productive, and it's given us some direction for staff to pursue and keep things moving. And like I think most things, it's always, we're always able to go back and amend this list in the future if we find out that we need to add or remove things when we move forward. But we definitely have allowed some more leeway for our medical directors to operate with the recommendation of moving that forward. All right, agenda item number 9 for possible action: discussion on filling the vacant volunteer fireman position on the Emergency Medical Services Advisory Committee. Bobby.
So, Mr. Chairman, Bobby Sullivan for the record, wanted to put out to this group, we are going to post this position again. It has been vacant since 2024 with no interest. So we're going to post it again. So I would ask that any of the committee members, if you know of anybody in the department meeting those guidelines, have them apply, and we'll get that going. But that was dovetailing into my comment about if we find somebody between now and time certain so that we could move it forward to get it on the Board of Health. I could play with those dates a little bit, or we could look to the May meeting So either way, we could certainly, because it's been vacant for so long, May would not be a reason.
One question for you, Bobby. At some point, if we're not getting the attention as that's structured, what would the process be to restructure that position on the committee to maybe expand it where we might be able to entertain it?
Take it to the legislature. No, if you, in order, because those positions are specifically in NRS, it would take a legislative change. Yeah, they're in NRS.
Is one to look at.
Yeah.
So we're gonna take another run at it and see what we can do.
I think most organizations are moving to the one where it's more like the position I hold, where it's a combination department, because most of them have some aspect of career staff, and they're not just volunteer anymore. And so that might be, maybe we look at the future of making it two positions that are a combination rather than, and that might be able to help fill that spot.
I'm gonna take some
down the road.
No, I'll take some of the, I just thought of something I can ask Steven, so I'll get back to you.
Any other discussion on that item?
I don't know if it's related, but it might be helpful also to consider if we are recommending any additional positions, having, because right now there's one position, correct?
Mhm.
So having one that might be maybe critical care flight or other EMS medical directors to get some more insight on some of those other.
I would like to see that too. All right, any additional discussion? I don't believe that this item would be for action besides what you're going to take as staff, correct? Unless any of the committee members would like to make a motion for action.
It's just discussion.
Is that one for possible action?
It should just say just discussion.
Yeah, it says for possible action and then discussion. So if I don't hear any motions for action, we'll go ahead and leave it as no action taken. And that'll be revisited on or table is for a future agenda item. So no action and table. And we'll move on to agenda item 10 for information only, establish meeting dates for 2026.
So I'm gonna defer that to Bobby Sullivan for the record to Mike. He pulled up quarterly dates that we can look at for the upcoming year, so.
Thank you guys, Michael Bolu for the record. So assuming that you guys would like to keep this third Wednesday of the month at 1:30, our meeting dates would be as followed for 2026. It would be February 18th, May 20th, August 19th, November 19th. I know November is always tricky because it gets around the holidays time, so we do typically flex that. That would also be an option, but if you guys would like that, I can put these dates in the team chat. But what are your guys' thoughts? Those would be the dates, keeping to third Thursday of the month, starting in February, third Wednesday.
Mark Pincus for the record, I'm good with those dates.
This is Kevin Grannis for the record. I don't have any issues with those dates.
I don't have any issues with the dates. I may not be able to make that February meeting, depending on some personal things I have in my schedule, but it's what we have a co-chair for, so I'm okay with it if everyone works for everyone else. All right, any discussion on that? All right, that was for our information only, and we'll move on.
That was me, sorry. I posted the meeting dates and times for the 4 agreed upon dates in the chat, so everybody has access to it in Teams, and then Rachel will send out save the dates to everybody. Well.
And we'll move to agenda item 11, second opportunity for public comment. Open that now.
I have a comment. I'm Amanda Brown from UNR Med, Office of Statewide Initiatives. We are going into our second year of the EMS Black Supplemental Grant, where we offer funding for recruitment, retention, training, and sustainability. And I would like to offer that to anyone on the call. The caveat is you have to be a rural agency or a rural serving agency. But if you could put my email in the chat, anbrown@med.unr.edu. I just want to offer that. Also, especially for rural areas, the Rural Health Transformation Program. There's been a lot of talk about it and a lot of interest in that fund, the funding from that. And I did work with Bobby back in October. But there's so much money in it, and we have to spend whatever award we're given now. We're talking like $100 million to the state at a minimum. And to put that into perspective, my office includes the State Office of Rural Health, and Gerald Ackerman, who's been there 30 years, hasn't even spent close to like 20 million in grant funding, and he is like a grant wizard. So I offer more information and support on that if people reach out and ask, but I also suggest that people keep an eye on just when that award comes out and to have some ideas in mind. If you do go on Nevada's website where they posted the proposal that they submitted, they don't really mention any programs specifically, and I would suggest no one get excited about that because they had 60 pages to spend $100 million. But again, to keep in mind how you might like to spend that money, to think of those think of ideas, and don't be cheap. Don't try to save money. It's a ton of money. And I'm really working to get EMS in there so that we can get funding for what is going on for Nevada, but it does have to be for rural and rural serving agencies.
Public, private, both?
Anything. We're just looking for programs to support health transformation in our rural areas.
Do you have any big examples of what's been funded, and like, are there anything that can't be?
It's a brand new grant. It's not really that things can't be funded. There's a few things about reimbursement for loans. So like for the physicians who go out to rural areas and get paid back travel. Yeah, some things, but they're really looking at how to consider just how we can redo some of the things differently and to invest in new programs. So we put in a few proposals, Bobby and I and Jamie from GBC, where we were saying we want more training. There's a patient safety and simulation program that UNR Med is trying to get off the ground. And we said we would love to attach an EMS link to that so we could get mannequins and people to travel and to train. We were also looking at an EMS advocate, just someone for the state who could go and like collect data, support EMS, and run around and do that kind of stuff. That's not necessarily a financially intensive thing, but something we would love to solidify with a grant like this. And we had a third one, Bobby. Do you remember what it was? The drones? Oh, yeah.
I can't remember.
I can't either, but just things like that. It doesn't seem like they'll support equipment. Oh, they won't support equipment or buildings. And it only is for 5 years. So they're not looking at extending it. It can't have a financial cliff. So we didn't suggest doing any community paramedicine because we've had more examples of those programs not being successful because once funding is cut, they just evaporate. But even considering like basically proposals about where you get money to get something off the ground to make it long term. That's what they're really looking at. Yeah.
And we're kind of brought to this late.
Yes.
But it was understood looking at that grant application, there had to be the EMS component. Yeah. So we're in there because it's in order for that to succeed, we've got to be in there.
Mm-hmm.
So we're kind of that key, but Amanda did amazing work on it when we got all the stuff together. And again, like she said, none of the projects would have a cliff to them because we've seen, how many of us have seen that over years? We see this project is great. It hits that time deadline and then it goes away because there's nothing on the other end to support it.
Yeah.
So, and to your question, you said rurals, we're talking rural statewide, correct? Not
yes. So, and when I say rural serving, that's something I kind of coined. I also run the EMS survey once a year. Part of that is looking at like parts of Washoe County are rural, parts of Clark County are rural, even though those are urban counties. So unfortunately, Carson City, they're out. They're totally urban, you know.
All in the middle every time.
I know, it's so unfortunate.
Not urban, we're not rural.
Yeah, but like Gerlach, Pyramid Lake, Mount Charleston, Boulder City, even those are rural. So if they're doing stuff in their flight programs, you serve rural areas. So that's where rural serving comes in. But if you want to do something for Las Vegas or Reno, we can't support that with that, or that program can't support that. Yeah.
And anybody that has any questions, please reach out to Amanda. She is well versed in this, and she has done amazing things to help EMS as a whole across the state. So please feel free to reach out to her.
Thank you, Amanda.
Thanks.
Any other public comment? On to agenda item 12, adjournment. You have a motion to adjourn? Motion second. Motion second to adjourn. We're adjourned at 15:06.
Thank you, everybody.
Thank you.
Have you seen the data on Farmer Joe?
Some.
Some